Yeah, so very good evening, everyone. So today's class is on approach to colectomies. Now, it's a very vast topic, a very wide topic, and can be very vague also. So, what we will do in this particular class is we will try and restrict ourselves to approach on colectomies predominantly for neoplasms rather than benign diseases or benign colectomies for the colon. And of course, we will be touching a lot of neoplastic topics such as colon cancer, rectal cancer, but we will not go into the depths or in detail or the nitty-gritties of colon and rectal cancers. But whatever is important from the surgical point of view, we will be covering that. Now, before we move on to the approach to the surgical part of the evaluation, first thing that we need to know is regarding the surgical anatomy. First and foremost is the fact that cecum has no mesenteric attachment. Okay, so normally you expect the colon to have a lateral attachment and a medial and a little bit of the posterior attachment as well. So because cecum does not have mesentery, it is only dependent either on the lateral or the posterior attachment. Now, sometimes in about 20% of cases, 20% of cases, there will be no attachment. So what does this imply? Who are the first years?
Suprit and Sai Likit.
Yeah, Suprit. Now, if I tell you cecum is a freely lying organ, what is its clinical implication?
Sir, it will be difficult to identify while
More than that, surgical, in surgery, what can happen? Now, why is sigmoid colon very famous?
torch. Sir, it will become torturous and ischemia will happen.
Torsion.
Yes.
Torsion can happen. All right. So, because if it has no attachment, it's very easy for it to rotate. Whereas if it has one fixed structure, it doesn't rotate. All right. Now, moving on to wall thickness, we know that cecum has a very thin wall. Can someone tell me what is Laplace's law? So, second years, who are second years? Ainas, can you tell me what is Laplace law? Okay, if Ainas is not there,
So,
Samir. Tell me, Ainas.
So it's basically the relationship of the like the pressure with the tension, sir. In a tubular structure, sir. Like the tension is directly proportional to the pressure, sir, and the rate inversely proportional to the radius, sir. So if the
Yes.
radius is increasing, the pressure will decrease, sir. And the same for the surface tension also it applies the same,
Can you
sir.
apply the same thing to cecum? Why have I brought in Laplace law for the cecum?
Yes, we can apply the same
Yeah,
principle,
so can you
sir.
tell me
Yes,
what
sir.
is the clinical implication of that?
So more the
Least
the
amount of
distension
pressure
or
is needed, sir, for it to
yes.
distend.
Pardon me?
Least amount of pressure is needed for it to distend, sir.
Why? Based on what? What are you based on?
Because it has the largest diameter, sir.
Excellent. So what it means is that when you have a larger radius, you just need a very minimal amount of pressure for it to distend. Now, to put it in much more simpler terms, I'm sure all of you have tried blowing a balloon. Initially, when you try to blow when it's very small, you have to put a lot of pressure to blow it up. But once it becomes big, it becomes very easy to inflate it. So what they're trying to say is the more the diameter of that particular organ, with very little amount of pressure, the distension can happen. And the fact that cecum has a very thin wall and a larger radius, it means that it has a highest chance of perforation. That is what is the clinical implication of all this. All right, it has a highest risk of perforation. Now, going forward to ascending colon, it is more or less a fixed entity. All right. So laterally, it is attached to the lateral peritoneal wall, and the condensation of that particular area is called as the line of Tolt. And if you go higher up towards the hepatic flexure, it does have some attachment to the kidney posteriorly, and that is called as the nephrocolic ligament. So basically what it means is that you have to incise this nephrocolic ligament in order to release the hepatic flexure whenever you're operating. And first years again, Sai Likit. Very straightforward question. What are the structures you're going to protect whenever you're doing a surgery on the right side of the colon? Only two structures, quickly. Back to Suprit.
Sir, gallbladder and liver.
Hey, two, okay. No, it's the ureter, because whenever you're dealing with the lateral surface, one is the ureter, second is the second part of duodenum. Do not forget this. If somebody wakes you up in the middle of your sleep also, you should be able to say this. Okay. So on the right side, two structures is ureter and duodenum. On the left side, it is only the ureter. Okay. Don't forget that. Now, transverse colon is one particular structure which is very free because it hangs between two fixed structures. That is the hepatic flexure and the splenic flexure. Splenic flexure is slightly higher up when compared to the hepatic flexure. Again, no clinical implication. Just the fact that it can be redundant. Like how you can have a redundant sigmoid colon, you can have a redundant transverse colon. And Nitya or Sanya, can you tell me what is the implication? Why have I written the word incision there? What is the clinical implication of having a very redundant transverse colon?
Sir, having more length of, like when we talk about right hemicolectomy and extended right hemicolectomy, we can resect more of it.
No,
Or
simple incision. Incision means something to do with skin or abdominal incision. How does it matter?
okay, it's easier to deliver with upper midline incision. We can
Okay,
easier
fair
to
enough.
deliver.
Done. Okay, okay, that was not what I had in mind, but I will take your answer. So I'm sure all of you have heard of something called as a blowout colostomy or a sigmoid colostomy that we do. Let us say if there is a big tumor which is causing obstruction, you don't need to do a laparotomy to do a colostomy. Yes or no? All
Yes,
you have
sir.
to do is make a small incision in the left iliac fossa, find the sigmoid colon, bring it out and make it a colostomy. Yes or no?
Yes, sir.
An emergency procedure that can be done. That's called as a blowout colostomy. Now, if you have a redundant transverse colon and you have an obstructing growth in the splenic flexure, it becomes very difficult to decide where you need to put the skin incision. Okay, so that is what I was trying to get at. And but one advantage is that this transverse colon is attached to a very long structure through which it is strongly attached. That is the great
Gastroc.
omentum.
Momentum.
Yes, great omentum. So all you have to do is make an incision. You will find the great omentum. Keep tugging on the great omentum, the colon will come to your hand. So it doesn't mean you always have to do a laparotomy. Even through a small incision for an emergency colostomy that we are going to do for an obstructive lesion, this technique can be used, and that is where the anatomy comes into picture. Next is with regards to descending and sigmoid colon. Nothing great about descending colon. Again, it is a fixed structure. Line of Tolt is there. But with regards to sigmoid colon, I have written redundancy. Now, can you tell me three important reasons why sigmoid colon can undergo a volvulus? So let's get Vinod.
Yes, sir. Sir, one is redundancy, sir, and one is high fiber diet.
Not high fiber diet, heavy stools.
Yes, sir.
Next, tell me anatomical thing, man.
Large mesentery,
Mesentery.
mesocolon,
Yes. Not large, long.
long.
Long mesocolon. So what this basically implies is that, so whenever you have your descending colon, the sigmoid colon will take a turn like this and come, correct?
Yes,
And then it's going to go down. So this is your mesocolon, correct?
yes, sir.
So whenever you have a narrow base, see, this is very narrow. So it can rotate around that narrow base. First thing. If it's a very long mesocolon, the longer it is, easier for it to rotate around the base. Okay, so those are the two important anatomical reasons. Redundancy, of course, the longer this is, the more will be the mesocolon. What do you mean by heavy stools? How does heavy stools impact or impact the sigmoid volvulus, Vinod?
More movements.
Huh?
More movements. Heavy movements.
In simpler terms, have you seen people trying to balance on a thread?
Yes, sir.
So they have both their hands out and they're trying to balance, correct?
Yes, sir.
Suddenly, if one side balance gets over, what will happen to that person?
Fall down.
Same way.
Topple.
Yes, they'll topple. So imagine you're having a heavy bowel movement here, and large quantity of solid feces, which is very heavy. Now, this weight itself can cause the sigmoid to rotate. If the majority of the stools is on one limb of the sigmoid and not in the other limb, it can rotate. Okay, so these are the 4 reasons why a patient can be predisposed to developing sigmoid volvulus. Now coming to rectum, rectum has 3 parts. You're going to have the upper, the middle, and the lower rectum. Upper is covered by peritoneum both anteriorly and laterally. Anteriorly and laterally. Middle, it is only covered laterally. Okay. Lower is completely extra peritoneal. Now, this becomes important when we talk about the various levels of rectal resections. I will be talking about anterior resection, low anterior, and ultra low anterior. So that is where this upper, middle, and lower will come into picture. Next thing is there is something called as the mesorectum. Okay, like we have mesocolon for the rest of the colon, but the arterial supply or the blood supply and the lymphatics are in a structure called as a mesorectum, which sits behind the rectum. Okay. Next, you need to know the attachment, so the relation of the rectum. Anteriorly, in females, you will have the vagina and the cervix. In males, you're going to have prostate and seminal vesicles. And that is separated by this layer called as the Denon-Villiers fascia. Okay. And posteriorly, there is something called as the Waldeyer's fascia. I don't think it's labeled here, but there is a Waldeyer's fascia here posteriorly. Now, behind this fascia, that is also called as the presacral fascia. Behind that, there are certain venous sinuses, and behind that is your sacral bone. Okay. Now, I'm sure all of you know this. This is a very avascular plane. So the idea is when you're operating, stay in the avascular plane. We'll get to that. But they say that if you breach this, you can cause bleeding from these venous sinuses. Can anyone tell me why it is dangerous? Nikita.
When we won't control with
We can't
arteries.
cauterize or control them, sir. We can't ligate them.
Why?
There are sinuses, not the proper veins.
Correct. I accept it. But what's more
And
dangerous?
location and the
Presacral plexus, sir.
Yeah, I'm telling you. No, see, I'm telling you, is it easier to tackle IVC tear or this one?
IVC tear is easy. Visibility and the location is the thing.
Correct. What's more important is once it tears, it retracts inside the holes of the sacrum.
Yes, sir.
Yes, sir.
Okay, it goes off inside the holes of the sacrum, and that is going to make your life a mess. Because at least if the sacrum is flat, you can put pressure and stop the venous sinuses. Okay, because it's against the bony structure, like even liver bleed also we put pressure and stop, right? But
Yes,
here
sir.
even pressure might not help because the bleeding might retract into the sacrum. So that is the reason they say do not breach this layer. Okay, it's a completely avascular layer. It's called as the holy plane. So they say stay in that plane whenever you're doing surgeries for the rectum. Now moving on to blood supply, colon gets blood supply from 2 of the major abdominal aortic branches. One is the superior mesenteric artery. Second is the inferior mesenteric artery. Pretty much straightforward. Superior mesenteric artery will give you ileocolic, right colic, and middle colic artery. Middle colic has a right branch and a left branch. The inferior mesenteric artery will give you the left colic artery, and it goes on down to become the superior rectal artery. Okay, pretty much straightforward. But what you need to know more is that there is a communication between these named vessels. That is, there is a communication between ileocolic, right colic, middle colic. through these as a marginal artery of Drummond. Okay, marginal artery of Drummond. Now this becomes important because it helps maintain the vascularity of an anastomosis. So what I'm trying to say is, even if you have tied off one vessel, that part of the colon can sometimes survive based on the blood supply you're going to get from the adjacent vessel also. And there is an other important vascular structure called as arc of Riolin. Can you see the small vessel which is coming? Now, this is a communication between the superior mesenteric and the inferior mesenteric artery. This is called as the arc of Riolin. Now, can anyone tell me what is the importance of this arc of Riolin? It is for a benign condition. I'm even giving you the clue. Whom have I not asked yet? Praveen. What is the importance of arc of Riolin?
Yes, sir.
There is something called SMA thrombosis, a very benign and a dangerous condition. Have you heard of it?
Yes, sir. Yes.
Yes. So in such scenarios, if you are lucky and the patient is lucky, this anastomosis between the SMA and the IMA can sometimes provide the vascular supply to keep that area of the bowel viable. Okay. So that is the importance of arc of Riolin. Now going on to lymphatic drainage. Now the mnemonic for it is EPIC. E stands for epicolic, paracolic, intermediate, and central. So the mnemonic is EPIC. Central is also called as the main group of lymph nodes. Now, whatever is adjacent to the colon is your epicolic. Okay, just adjacent to the colon. Then whatever are on your marginal artery of Drummond, that is your paracolic. Whatever is on your named vessels like right colic, middle colic, ileocolic, these are your intermediate group of lymph nodes. And whatever is at the root of these vessels, that means near the IMA or the SMA, these are called as central or main group of lymph nodes. Please remember this because this becomes important when we are talking about lymphadenectomy. The amount of lymph nodes to be removed, what is the level of the lymph node to be removed? This particular slide or image will come into effect at that point of time. So I will repeat, epicolic is which is just adjacent to the surface of the bowel wall. Paracolic is along the marginal artery of Drummond. Intermediate is along the named vessels like the right colic, the left colic, the middle colic, and the ileocolic. And the lymph nodes that are present at the root of the SMA or the IMA are called as the central or the main group of lymph nodes. Now, quickly, somebody tell me what is the presentation of a right-sided colonic cancer versus a left-sided colonic cancer? Let's get in the first years first. Sai Likith is not there, huh? Or he's choosing not to open his mouth. I don't know.
Sir.
You're there.
Hello.
Yeah. Okay.
Sir.
Tell me, Pa, how do you differentiate between a right side colonic cancer and left, and why is it so?
The left side presents with
I've given you the answer here. You
intra.
just have to look at the first line of both sides and just tell me.
Left side presents with intraluminal mass.
Right side also intraluminal mass. Where else will it go? It can't go extraluminal. Okay, next. Who is senior to Sai Likith? Ainas. Jaldi, jaldi. Otherwise, you won't be able to finish. Okay, Vinod, go for it.
Sir, on the left side, mostly they will come with obstruction and change in bowel habits and tenesmus. And on the left side, on the right side, they will generally will be with anemia and weakness and
Yes.
black color.
Can you tell me why? You read out what I have on the slide, you have understood it, but can you tell me why that is so?
Yes,
Simple
sir.
common sense.
In the right side, the stools will be loose, watery, and on the right, on the left side, it will be hard because of colon will absorb all the water. So because of that, obstruction will be more.
Partially right, but I will make it much more simpler for you. Okay, see, whenever there is liquid, it is easy for the tumor to go straight into the lumen. Okay, because liquid does not give any resistance. So it will grow straight, it will grow like a cauliflower. Now, the farther it goes away from its blood supply, it can start bleeding from the tip of the tumor. Okay, like let us say this is the colon, the cecum. Now, the tumor can start growing like this from one end. So the farther it goes away from the blood supply, this area can start bleeding. So eventually they present you with a big mass in the right side of the colon. Okay. Whereas on the left side, because the feces is very hard, it does not allow the tumor to push through it. So what does the tumor do? It will try to go around the feces. Okay. So rather than it trying to grow like what it was like this, it will start growing circumferentially. All around the colon, it will grow like this 360-degree. Okay. So that is what we call as a napkin ring appearance. So it starts going around circumferentially, it starts going around the tumor, and gradually it will keep on becoming narrow and it causes obstruction. Here, irrespective of how big it becomes, the liquid can easily find a way around it and get out. That is why right-sided colon does not present with obstruction. Instead, it is the left-sided colonic cancers. And because it's a slow growth, the patients don't even realize there is a growth. So there'll be constant, slow amount of bleeding going on inside the colon. And by the time that feces comes out, it'll only be occult blood. It will not even be melena. That is why they'll have chronic, slow anemia and weight loss and all that other symptoms that you're saying, like loss of appetite, loss of weight. But that will not be there with the left-sided colon. Left-sided will come with obstruction. Second is this altered bowel habits. Basically, they'll have constipation because of the growth and loose stools because of the amount of mucus that is being produced. So the mucus that is coming out is the spurious diarrhea. It is not true diarrhea. They're having constipation because of the growth, but the diarrhea that's happening is because of the mucus and not because of loose stools. Last one is tenesmus. Now, if somebody forcefully holds your hand, your intention is to always try to release your hand and get away from them. So same way, if there is a growth sitting in the rectum keeps constantly getting stimulated to evacuate it. Okay, like if feces come and sits in the rectum, once the rectum distends, it wants to throw it out. But now there is constant feeling of something sitting there because it's the tumor which is sitting there. So the patient will feel like he has to keep going to the restroom very often. That is what tenesmus is, feeling of incomplete evacuation. And irrespective of how many times he goes to the washroom, they do not feel comfortable. Okay, so that is what is tenesmus. Now moving on to diagnostic evaluation. Most important step is colonoscopy. Okay, first you will do a colonoscopy. Now the idea of colonoscopy is for localization, to know which part of the colon the tumor is in. The tumor can be here, splenic flexure, transverse, hepatic, wherever it is. But what is the tricky part? The tricky part is that rectum and cecum are the only two areas that you can confidently say that if you look at it, yes, this is the rectum, this is the cecum. When you're doing a colonoscopy, when you're seeing from the inside. Rest of it more or less looks the same. It's easy to describe. Triangular means transverse colon. Then you will see splenic flexure, you'll see hepatic flexure. All that is easy to say, but you can't be reliable. It can't be reliable. Okay. The reason why I'm saying this is that if the tumor is very, like let us say we are doing a laparoscopic surgery. Okay. If the tumor is big, it would have come outside and you can see it on laparoscopy. But if the tumor is small, how do you know where to cut? You'll not even be able to identify it. Okay. Some in the, let us say the colonoscopy report, they would have said it is at 120 centimeters. Can you sit and measure 120 centimeters from the anal canal inside when you're operating if nothing is seen on the serosa? You cannot. Okay, so that is a bit tricky. Next, the advantage of colonoscopy is that you can get tissue diagnosis. You can take a biopsy, confirm your finding, and then probably give the patient neoadjuvant treatment depending upon the stage. If it's a rectal cancer or for colonic cancer, you'll get an initial diagnosis to go ahead to do the surgery. Now, coming back to my question, if the tumor is very small and you're posting the case for a laparoscopic or a robotic colectomy, and you don't know, and I've already told you it is very unreliable in colonoscopy. What is the other way of trying to identify where the tumor is? Nikita.
Intraoperative colonoscopy, sir.
I will ask you one more question. If I do an intraoperative colonoscopy with lot of air and I insufflate it into the colon, what will happen on table for me when I'm doing laparoscopy?
It will alter the vision.
I will
Space will
not
decrease.
have space to operate, correct?
Yes, sir.
Yeah. So can you think of something else? Vinod or Praveen, whoever is unmuted, go for it.
Sir, capsule endoscopy.
What endoscopy?
Capsule endoscopy, sir.
What?
Capsule endoscopy, sir.
Capsule
On
endoscopy is for
table.
small bowel. It is not for large bowel. Let's not get confused. Anybody else?
Preoperative marking, sir.
Exactly. How will you mark it? What is it called?
Dice or
Yes, the word is almost there. You're not getting the word. That is called as tattooing.
tattoo.
Okay, you inject a dye in and around the site of the tumor. What's important is that it should be done by an experienced person because the dye should be in the intramural. That means within the walls of the colon. Do not push the needle too much. That time you can go transmural and put the dye inside the peritoneal cavity. If it goes transmural, it can cause a lot of adhesions. Now, please note you are doing this one day prior to the procedure, correct? The previous day you have done a colonoscopy and then you are doing the surgery the next day. So it can cause a lot of adhesions and make your case a lot more difficult. So you can see here is a very small tumor. They are injecting all around it. Okay, injecting all around it. And this is how it's going to look on table. Okay. See, if you just look at the colon per se, can you even make out there is a tumor underneath that area? You can't, right? It's not like an obvious growth. So that is the role of tattooing with the help of colonoscopy. Now coming to what Nikita said, if at all this technology is not available with you, you can try to do an intraoperative colonoscopy, but use it with carbon dioxide instead of the regular air. Because they say carbon dioxide is easily absorbable. So that time that distension might come down much faster as compared to the other times. So that might make your surgery a lot more easier technically. So now you have confirmed the disease. Next, you have to stage the disease. Staging, the best option is to do a CECT abdomen and of the chest to look for metastasis. And I've also written MRI and ERUS. Can someone tell me why? I will go to the registrars, Nitya or Sanya, one of the two.
Sir, because MRI, we can see the soft tissues properly. In colon cancer, the uh, peritumoral, when we go to the mural spread and the pararectal fascia, then the MRI is better, sir.
Bone, sir. Pelvic bone, we can't do CECT because rectum will be in the pelvis.
Both of you are correct. See, CECT will help you look at lymph nodal spread. MRI will look for soft tissue spread. Okay. Now, soft tissue spread, I'm only concerned when it comes to the rectum because there are very vital structures such as the internal sphincters. Forget about the fascia and all. Okay, mesorectum and all you leave. Sphincters are there, right?
Yes, sir.
If it spreads to the sphincter, there is no role of local resection. We'll end up doing an abdominoperineal resection for the patient.
APR.
That is the role of MRI. Now, MRI will help you differentiate between T3 and T4 disease. It cannot help differentiate between T1 and T2. It is not that sensitive. Okay. Now, coming to my next question, why have I written plus or minus ERUS? How does it matter whether it is T1 or T2? ERUS is the best to differentiate between T1 and T2 diseases.
It will tell about the layers, the layer
No,
of involvement.
that I know, Pa. I am asking you a simple question. What is the clinical implication? Whether it is T1 or T2, how is it going to change my treatment?
Sir, we can try with step though.
Endoscopic
resection,
endoscopic
endoscopic
resection.
resection, mucosal resection.
local
What is it
resection,
called?
transanal resection also we can try.
That is only endoscopic resection, but what is it called? The terminology.
Yo,
Transanal
Titanium
minimally invasive surgery.
TMIS.
TAMS. Okay. So
Yes.
if you want to look for T1, T2, ERUS is the best. MRI will not give you the answer. Okay. Now again, one more simple, I just want to add one more. Now I've told you if it is T2, you can't do TAMIS. Okay. Only T1 is for TAMIS. Why not T2 for TAMIS?
Sir, submucosa will have the lymphatics through which the spread will be happens.
Exactly. So whenever you're doing an endoscopic surgery, most of the times you're only addressing the mucosa, submucosa. You cannot address the mesorectum. Okay. If you leave behind lymph nodes there is no point in doing an endoscopic surgery. That is the idea. Okay. In simple terms. Now let's move on to preparing the patient for surgery. Mechanical bowel preparation. I want you guys to tell me what is the impact of mechanical bowel preparation on anastomotic leak, reoperations, readmission, and mortality? The answer is the same for all four. I want you guys to tell me, will it improve this or will it deteriorate this?
No change, sir. Actually.
No impact.
Left-sided colonic surgeries in comparison to the right-sided.
I take your answer, but my question is straightforward. In terms of anastomotic leak, reoperations, readmissions, and mortality, do you think bowel preparation makes a difference?
No.
Does it improve it or does it worsen it?
No change.
No change.
No change.
Statistically no change.
Excellent answer. No change. Okay, no change. The only thing that has been found to have an impact is on wound infection. Okay, they say that the skin or the superficial surgical site infection, that the SSI, tends to be lower in patients who have undergone a mechanical bowel preparation. Now, just to tickle your brains a little bit more, only mechanical bowel preparation versus no preparation versus mechanical bowel preparation with oral antibiotics such as rifaximin. Which of the three would you choose?
Bowel preparation with
antibiotics.
Antibiotics.
Why?
That wound infections also will.
You give IV antibiotics. No, why oral antibiotics? I specifically said oral.
Oral prophylactic
colonic
antibiotics 1 day
bacteria.
prior.
Yeah.
How?
Sir, IV it won't change because oral.
No, sir.
It will directly
They
act on
reach
the
the
oral.
area of the
Colonic
like
bacteria.
The absorption will be minimum, bioavailability. So it will be available only in the gut.
sir, they
Okay, I will
reach the
make it much.
biota.
You guys are getting there, but again, all of you are thinking in terms of textbook and what you have read there. I want you to think with a little bit of sense. When you give that bowel preparation, all the feces becomes liquid. It washes away all the bacteria from the, let us say, the wall of the colon when it gets washed off. Now, if it gets washed off, where are all these bacteria? They're sitting inside that liquid feces. Okay. So now you are having a colon with liquid feces, which is rich in bacteria. So if you don't give oral antibiotics, it tends to worsen the risk of infection as compared to no bowel preparation. Okay. So give bowel preparation, but give it along with rifaximin so that it also washes away or reduces the effect of the bacteria which is there in that liquid feces. Okay. Clear
Yes.
or any doubts?
No doubt.
Excellent. Now let's look at the various guidelines or the various data available Now they say open surgery, they say there is no change whether you do bowel preparation or whether you do it. With minimally invasive, they recommend it. They recommend bowel preparation purely because you'll have to lift up the colon, move the colon. So if it is loaded with feces, it becomes difficult to handle it. Then you try to grasp the colon, there's a chance you can cause perforation. So that is why they recommend doing bowel preparation in minimally invasive surgeries if you're doing lap or robotic. With regards to colonic surgeries like right colectomy, left colectomy, no, they're saying there is no change. If you want, you do it. If you don't want, you don't do it. That's left to you. But rectal resections preferably give bowel perforation. Again, recommended because the feces are very hard in the bacteria tends to get concentrated more in the left-sided colon. So they recommend it. And second thing is left-sided colon or anterior resection. You have to lift up the bowel, go behind the bowel in the mesorectum. So having a heavy intestine there makes it that much more challenging because the pelvis is a very narrow structure. So the smaller the bowel, more is the space for you to work. Last point, which goes in favor of giving bowel preparation is in case you have to do intraoperative colonoscopy, like what you just suggested. So there you might, it is always better to give them bowel preparation in case there is a role for intraoperative colonoscopy. Now moving on to surgical techniques, I will not go into the in-depth details, what incision, what we are doing. I will just cover the main points that are needed for your exam point of view. First is what is the margin that you need to take, distal and proximal. Various papers and guidelines suggest 5 to 7 centimeters, but there's a textbook called as Mastery by Fisher. Okay, Fisher's Mastery of Surgical, I have forgotten the name, Fisher's Mastery. There he's mentioned 10 centimeters as the margin, 10 centimeters proximal, 10 centimeters distal. For rectum, it is 2 centimeters and this is a fresh fixed sample. Can someone tell me what that means? Why have I specifically mentioned fresh fixed sample?
If it happens late, there will be retraction.
Yes. So what I'm trying to tell you is take a 2 centimeter margin on table. Okay, like for low anterior resection or ultra low anterior resection, measure it and then put it into formalin and send. Because once you put it into formalin, everything shrinks, it gets dehydrated. So what is 2 centimeters might become 1 centimeter. And if the pathologist reports it as 1 centimeter, do not panic. That is all what I'm trying to say. Okay. So it is your decision that is on table, which will influence the further treatment of the patient and not that 1 centimeter which the pathologist has written. I'm not saying the pathologist is wrong, but the pathologist is commenting on a fixed sample. That is a formalin fixed sample, but you should measure this in live. Okay, like in a non-stretched state, you measure it live. If it is 2 centimeters, well and fine. Then put it into formalin and send the specimen. All right. Now I tell you, all this is rubbish. Why? We read what the guidelines say, but we don't stick to it. Why?
Because we do larger colectomy, sir. We do complete right hemicolectomy and
Why?
we
Again,
go with lymphatics and
Vascular.
larger.
excellent
Yeah.
answer. Excellent answer. The idea is we don't sit and measure 5 centimeters from the tumor. We try to take out the lymphatics. And if you have to take out the lymphatics, you end up taking out the blood supply. So it usually depends upon how much of the colon is devascularized, and you will take out that much. Invariably, you're taking out more than this recommended margin. So you're never bothered about recurrence at the anastomotic site. It is extremely rare, except in rectal cases where you can't toy around with this because you're very close to the sphincters. In colonic cancers, very, very rare or unheard of to have local recurrence. Okay, so the recurrence is usually in lymphatics or lymph nodes or distant metastasis, which could have got missed if you have not ligated the vessel properly or if you have not taken out the lymphatics adequately. Now, coming to the procedures performed, it depends upon where the tumor is. If the tumor is in the cecum or ascending colon, you will do the conventional right hemicolectomy. And the vessels ligated are your ileocolic, right colic, and right branch of middle colic. But if the tumor is in the hepatic flexure or the transverse colon, then the procedure is a right extended hemicolectomy. The vessels ligated will be your ileocolic, right colic, right and the left branch of middle colic, or you can just say trunk of middle colic. Both are accepted. And for splenic flexure and descending colon, the procedure that's being performed is called as a left hemicolectomy. And the vessels ligated is your left colic artery. Sorry, not the left colic artery. It is the inferior mesenteric artery, the IMA. Okay, it's the IMA that is ligated. So this is a diagrammatic representation of whatever we just discussed. Okay, everything in the cecum or the ascending colon, conventional right hemicolectomy. You can see ileocolic is taken, right colic is taken. This is the middle colic. There are two branches. So you're taking the right branch. So then you're going to call it as a right colectomy or a right hemicolectomy. But if it is beyond the hepatic flexure and the proximal part of the transverse colon, you will do a extended right hemicolectomy where it is ileocolic, right colic, and the trunk of middle colic. Can you see? They've taken out the trunk of middle colic. So this is a extended right hemicolectomy. Now, question to first years. Is there something called as limited right hemicolectomy? If yes, which are the conditions you're going to perform this in? Suprit.
I don't know, sir.
Okay. Samir. Okay,
No,
next.
sir, not yet, sir.
Okay, next person. Limited right hemicolectomy, who knows?
Sir, appendicular carcinomas.
Fair enough. Can you tell me a benign disease? Let's not get into cancers. They'll again get confused. That's why.
Something like adenomas and lipomas of this ascending colon.
Interception, sir.
TB.
Yes, sir.
Ileocecal tuberculosis. That also what variant? There are two types, right?
Yes, sir. Immunized patient, hypertrophy.
Hypertrophic and ulcerative. In hypertrophic, when it is causing intestinal obstruction or narrowing, you can do it. And also somebody else commented, I think Siddharth commented saying it is for an unhealthy appendix. Sorry, acute appendix with the base unhealthy. But usually, Siddharth, we do not do a limited right hemicolectomy. That is an option. Instead, we just take out that cuff of cecum and stitch it up. Okay. We just take out the cuff of cecum and stitch it up. That is called as a cecectomy, where only because the cecum is such a big structure, you can afford to take off even half the cecum and still get away with it because it has a very large radius. So this is the left hemicolectomy. Like I said, you will take out the inferior mesenteric artery and this part of the colon is taken off. Pretty straightforward. Now, coming to the techniques, there are two ways of approaching a right hemicolectomy. One is the medial to lateral approach. Sorry. This is the lateral to medial approach. This is what I think most of you would have commonly seen. Okay, lateral to medial approach, where what you're going to do is you're going to incise the line of Tolt. Line of Tolt is incised and you're going to medialize the colon. Okay, you will go into the retroperitoneal structure, you will medialize the colon, you will release the nephrocolic ligament and the hepatic flexure and pull everything down so that you bring the colon to the wound and then look at the vessels, ligate it and take it off. The other technique is the medial to lateral technique. Medial to lateral technique, where first thing you're going to do is you're going to incise the peritoneum, find the ileocolic, the middle colic, and the right branch of middle colic, ligate those vessels, and then get to this colon. Now, why do they have two separate techniques? What is the advantage of lateral to medial and what is the advantage of medial to lateral? This I want the registrars to answer.
Sir, in laparoscopic techniques, we generally prefer medial to lateral approach, and in the open, it is usually the lateral to the medial approach.
No.
Sir, bleeding will be well controlled in medial to lateral approach.
What will be very controlled?
Bleeding.
No.
Because we are ligating the vessels first.
No. Okay, simple. Idea is, or the theory behind it is that whenever you handle the tissues, there can be tumor embolus which gets out into the blood vessel and then can spread into the body. Okay. So when you're going, like for example, let us say you're operating on a patient with an abdominal trauma. He has a ruptured spleen. You go in. What is the first thing you do? Divide the ligament of spleen, or first find the splenic artery and vein and ligate it.
It's like ligate the vessel. Yes,
You're
sir.
going to try and stop the blood supply,
Yes, sir.
and then you sit and do the attachments, whatever you want. This is for trauma. Whereas in an elective case, we tend to first separate it carefully, then come to the blood vessel because you have a lot more access, and then tie it up.
Yes.
Correct? Same thing here. Whenever they say that if you're handling a tumor, and if you try to do the lateral to medial, because you're holding the colon, lifting the colon, moving it, mobilizing it. So during mobilization, they say that you can have a tumor emboli which goes into the blood vessel, and that can cause distant metastasis. So what they say is you first tie off the blood supply. Make sure it doesn't spread anywhere. Don't even touch the tumor. Catch out of the mesentery, identify the blood vessels, ligate the blood vessels. Don't allow the tumor emboli to spread. Then you do whatever you want with the bowel, they don't care. Okay, of course, not perforate it and all, but that is the idea behind a lateral to medial versus a medial to lateral approach. Now, this is the advantage of medial to lateral. Advantage of lateral to medial approach, that is this technique. This is what I'm sure most of you would have commonly seen.
Yes.
This is because it's very easy. Because you're going in the line of told avascular plane, nicely you're mobilizing the cecum. Cecum will come, or the entire ascending colon will come into the surface of the wound. Now you can aramse look at the vessels and ligate it. This is a lot easier to do. Okay. Whereas this, most of the oncologists prefer this technique, where you go medial to lateral approach. Now, two structures I told you that you have to protect is ureter and the C loop of duodenum, inside which the head of the pancreas is there. Okay, the head of the pancreas, that is where it is. So two structures, like I said, ureter, which comes laterally, and D2, or the curve of this duodenum. You see, it actually creeps up very fast. As soon as you make the incision, you'll be able to see it down. Okay, those are two structures that have to be protected. Technique when you're doing a left hemicolectomy is go to the level of the sacral promontory. Sacral promontory. At that level is where the origin of the inferior mesenteric artery is. Okay. All you have to do is pick up the peritoneum there, make a small incision on the mesocolon. You will find the inferior mesenteric artery there, and you can trace it to the root and ligate it there. So that is the technique for a left hemicolectomy. Now moving on to the lymph nodes. I kind of vaguely touched upon it there, but here I will go into the depths a little bit. First and foremost, minimum lymph nodes that have to be harvested to get a good adequate staging of the tumor is 12 lymph nodes. Now they say there is something called as a D2 versus a D3 lymphadenectomy. I have shown you in this image. So let us again put that. E, then paracolic is the Drummond, I is along the named vessels, and C is, or the central or the main vessels are near the root where the SMA and the IMA are. If you remove the lymph nodes up to the level of the named vessels, that means intermediate. This is also intermediate. So if you remove up to intermediate vessels, that is called as D2 lymphadenectomy, up to intermediate. If you go beyond it and you go to the root and you take out the lymph nodes next to the superior mesenteric artery or the inferior mesenteric artery, that is called as D3. So D3 is when you take out central or the main group of lymph nodes, and this is also called as high ligation. That means you're going to the root of the vessels and you're going to take it out. Now, if I ask you, is D2 better or D3 better, which one would you choose and why? Think practically also.
It will be easier, sir, for surgically.
Huh?
D2 better.
Practically, but for the
Practically.
patient, it is shown that D3 is better
Three.
because it improves the disease-free survival.
Yes, sir.
Okay. But the risk is that, please note that forget about inferior mesenteric artery. That is pretty easy to tackle. Superior mesenteric artery is a major blood vessel which supplies the small intestine.
Major.
So while trying to handle that, if you traumatize the superior mesenteric artery, there is no coming back. It is a major blunder. Okay. So that is why some people are a bit worried to do a D3 lymphadenectomy. But now what they do suggest is do a D3 lymphadenectomy. That is the best because it improves the disease-free survival of the patient. Now, can anyone tell me what is the newest terminology that is being used? Have you heard of CME? Don't say continued medical education.
Circumferential mesorectal excision.
Circumferential
Mesorectal excision.
excision.
Somebody said something else apart from that.
Complete.
Complete
Ah.
mesocolon excision, sir.
Correct. Circumferential mesorectal, that is TME, total mesorectal excision. There's nothing called circumferential. Okay, that is for rectum. For colon, they are nowadays calling it as a complete mesocolic excision. Because they're taking out this entire thing, right? So technically the entire mesocolon is being removed. That's why it's called as CME, complete mesocolic excision. We're not talking about rectum. They're still in colonic cancers. Now, quickly, one of you, I think I'll go to Nitya only because we will otherwise run out of time. Nitya, can you tell me quickly what is anterior section, low anterior, ultra low, intersphincteric, and APR?
So anterior resection is for the rectal cancer, which is at the upper 1/3 of the
Okay,
rectum.
I will make it simple. Tell me where is the line of anastomosis. Forget about where the tumor is. Where should the anastomosis be?
Intraperitoneal, sir.
Huh?
Intraperitoneal.
Above peritoneum.
Yeah, above peritoneal.
Low anterior?
Is below peritoneum.
Below the peritoneal level.
Ultra low?
Less than 2 centimeters.
Of what?
For the anorectal junction.
Correct. If it is within 2 centimeters of the anorectal ring or the anorectal junction. Intersphincteric is?
Between the sphincters.
You go into the anal canal and excise a bit of the anal canal also. So basically at the end, you will have what we call as a colo-anal anastomosis. So please note, till now we either had colocolic or colorectal anastomosis. Now we are directly anastomosing it to the anal canal. APR is when you take out the entire thing. Now, for those of you who are confused, I'll make it easy with images in the next 2-3 slides. Please pay attention, very, very important. All right. So this is your peritoneal reflection, right? So let us keep in mind that margin, 5 centimeter ka margin, whatever we discussed. So wherever the tumor is, you have taken 5 centimeters. And then if your anastomosis, okay, that is your colorectal anastomosis, is above the level of the peritoneum, you are going to call it as an anterior resection. If it is below this peritoneum, that means anywhere here if the anastomosis is there, then you're going to call it as a low anterior resection. Now this is your anorectal junction because anal canal is 4 centimeters, correct? Anything above that is called as the rectum. So if it is very close to this anorectal junction, that means within 2 centimeters. If the anastomosis is within 2 centimeters of this area, then you're going to call it as a ultra low anterior resection. If it is within 2 centimeters of the anorectal junction. Next is your intersphincteric. So normally the idea is to preserve the internal and the external sphincter. But sometimes the location of your cancer will force you to take the internal sphincter also. But if you can get away by taking only a small bit of the internal sphincter like this, that is called as the intersphincteric resection, where along with the rectum, you're taking a part of the anal canal also. Okay. So it is rectum plus a part of the anal canal and leaving behind a small bit of the internal sphincter. That is called as the intersphincteric resection. Last is, if there is no choice and you have to sacrifice both the internal and external sphincter, you might as well remove the entire thing. That is called as a APR, abdominoperineal resection, and you will end up with a permanent end colostomy. Okay. Any doubts in the terminology before we go ahead? If you have doubts, you can even put it up on the chat box.
No, sir.
Chalo. Next. One last thing. There is something called as high ligation of inferior mesenteric artery. High ligation means above the level where the left colic artery arises. Now, I hope you're understanding why I'm coming to this point. Let us say the tumor is here. If I do high ligation of inferior mesenteric artery, I have to remove this entire thing. Yes or no?
Yes, sir.
Now, for this small tumor, do you want me to remove so much of the colon? I need not. So that is why they have said something called as a low ligation. That means as soon as the left colic artery takes off, ligate it there. Okay, as soon as the left colic artery, you ligate it there, and they have found out the survival is the same. So when it comes to inferior mesenteric artery, high ligation is not compulsory. They have found out that high ligation is not superior. So instead, if you save the left colic artery, you can probably remove so much. Okay, you can remove the sigmoid colon and retain a good amount of the healthy normal intestine. Okay, so that was one extra point. Now, in the left colonic surgery, that means when you're moving the left side of the colon, this you need to remember, you will come across three tubular structures. The first of it is your inferior mesenteric artery. That is the first tubular structure. Second tubular structure is your ureter. Third tubular structure, can you tell me what those vessels are?
Gonadal vessels.
Gonadal vessels. Okay, gonadal vessels. So do not cut anything. So when you're going or when you lift up the medial to lateral approach on the left side of the colon, identify all three tubular structures and please don't cut either of the three. Of course, you have to ligate the inferior mesenteric artery, but till you identify all three structures, do not ligate or cut anything because there is a high chance you would have picked up the ureter or the gonadal vessels and you can cause a lot of bleeding and a lot of problems for the patient. All right. So don't get into that janjat. Next, coming to the mesorectal excision. Can anyone tell me why they have come up with the terminology total mesorectal excision? Why should the entire mesorectum be removed? Again, I'll go to Nitya. I think it'll be easier if you answer. It's a bit advanced.
Sir, it's for the lymph node, complete clearance of the lymph node, sir.
Correct. So even though I'm contradicting my statement, I told you in rectum, even 2 centimeter margin is sufficient. I told this, right? But if you have rectum like this and mesorectum behind it like this, they say that wherever the tumor is, it can spread lymph nodes in the mesorectum 5 centimeters away from where it is. So theoretically speaking, I can take out, just give 2 centimeter margin. That's quite sufficient. But there is a chance that if I do the surgery here, I will leave the lymph nodes behind. That is why they say total mesorectal excision. Okay. This problem doesn't arise with colon because colon has blood vessels in a big sheet. Okay. The entire mesocolon is spread. Whereas in rectum, it is condensed. So the distant spread in terms of lymph nodes is much farther in rectum as compared to colon. That is why you do a total mesorectal excision. So anteriorly, inferior hypogastric plexus, you have to save. When you're releasing the lateral stalks, you will have your middle rectal artery. So be safe, you can cause bleeding from there. Posteriorly, like I said, if you damage the Waldeyr's fascia, you can have bleeding from the pre-sacral venous plexus. Okay, it's a bit too much of detail for you, not important. Quickly, 2 or 3 more slides. One is regarding anastomosis. Now, so far, everything was on clinical base. That means you have removed, you have ligated the vessels. You will see up to what level the bowel is dusky, and you used to cut it there and do the anastomosis. The alternate is to do the ICG. Okay. So here you can see they have given the patient ICG. This is the vascular part. ICG will get into the blood supply. You're going to use a near infrared technology. See up to what level it is vascularized and resect it at that point. Now, if I ask you, is clinical better or ICG better? What is your answer?
ICG.
Why?
Sir, if vascularity is there, it will go. Otherwise, it won't. Definitely, it's something like.
Correct. Because clinical is subjective. ICG is you can see it. Okay, it's like a CT scan. It is there for everyone to see. All right. So they found out that the line of resection changes. Like clinically, I would have decided this is where I want to cut. But after I give ICG, I'll probably go more farther or go much more behind after I give an ICG. And they found that the leak rates are actually much lower whenever you use ICG. So probably going forward, ICG will be the baseline of the routine modality that has to be used based on the current data that is available. So this was one paper where they compared clinical versus ICG. So this line B is clinical. Okay, clinically they came up with one particular line. Like in various cases, the surgeon felt this is where we have to cut. And after giving ICG, in almost 88% of cases, the surgeon actually changed his line. Okay. Most common is they went more farther away. That means they tried to save that much more colon. Very rarely, in only 6% of cases, they went higher up. That means the surgeon felt, no, what I've thought, there's not enough vascularity, I need to go higher up. Okay. Bottom line is your whatever you have seen with your eye, there is a high chance you will either progress further ahead, much more distal, very less chance of you progressing behind, but ICG is better than open eye. Quickly coming to anastomosis. Which anastomosis has a higher chance of healing? Ileocolic, colocolic, or coloanal?
Coloanal leak high leak.
Hmm?
Coloanal is high leak.
What question I asked you, what you're answering? If I ask you your name, you're answering roll number.
Sir, high leak
Ileocolic
was.
is
I'll
more
call it,
healing
sir.
Yeah,
because of
this has the best healing.
best vascularity.
Yes, because ileum has more amount of vascularity. That is why they say ileocolic has a best chance of healing. Now, if you think back, you have, what is that? Hepatic flexure growth. Why do you have to remove entire ascending colon and ileum and do a extended right hemicolectomy? Why can't you just remove a segment of the colon and do a colocolic anastomosis? This is the reason. Okay. It is better to take out the IC junction, get an ileum, anastomose it to the transverse colon, and it heals better that way. Okay. So ileocolic is best, followed by colocolic. That means your left hemicolectomy. And coloanal anastomosis, which surgery do we use this?
Intersphincteric.
Correct. Intersphincteric resections. Very, very rarely where the ileum, where the colon is anastomosed, the anal canal. Now, this has the highest leak rate. Okay, so it has the worst healing of the three. Coming to the type of anastomosis, it can either be end to end, side of the ileum to end of the colon, side of ileum to side of colon, side of colon and end of ileum. So end to side anastomosis. Of these three, the most preferred is the side to side. Most preferred. But if you look at it, all have the same rate of healing or the same rate of complications. They've only thing that they've mentioned in one particular paper was that end to side. No, sorry. The side to end, where side of the ileum is anastomosed to the end of the colon. Here they found complication rates were higher. Okay, in only one paper. But otherwise, general consensus, whatever you do, everything is accepted. But what is most preferred or what they most commonly use is a side to side. Simple question, why? Why do people prefer side to side?
One is anastomosis, sir, and one more is strictures. Will be more with end.
If everything is same, I have just told you, everything is the same. Stricture, blah, 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 everything is the same. Still, why side to side?
Easy, sir.
How many open, have you, okay, if given a chance, would you prefer laparoscopy or open colectomy?
Open.
Hey, not for you, man. If you are a surgeon, do you want to do open or laparoscopy?
Depends on the stapler or the hand sewn, sir. Hand sewn.
Yeah, exactly. A stapler will fire a side-to-side anastomosis. That is why it is the most preferred. Simple, no high funda, simple common sense. End-to-end is if you are doing hand-sewn anastomosis. So nowadays, minimally invasive techniques have gone up. Okay, so everyone wants everything to be done intracorporeal. They want intracorporeal anastomosis, everything they want inside. So in such a scenario, it is easy to fire a linear stapler. End-to-end anastomosis, you will do when you're doing rectal surgeries. Okay, but if you're doing a ileocolic anastomosis, very rarely you will do end-to-end anastomosis intracorporeally. Inside the abdomen, you never do this. If you're bringing it out, then you do a end-to-end anastomosis. Finally, when it comes handling obstructed bowel, whenever the patient goes into obstruction, it automatically means that it is at an advanced stage. That means it has gone to such an extent and caused a constriction. It reduces the disease-free survival. Location of the tumor. They say right side has worse prognosis when compared to left-sided obstruction. Again, simple common sense. Why?
Early presence.
Huh?
Early presentation, sir. Left side will be presenting early.
Correct. Because left side has a circumferential growth, so it can grow all around and cause compression. Whereas if a right-sided tumor has to cause obstruction, it has to grow into the lumen to such an extent that it blocks off the entire right-sided colon. Okay. Now imagine if a tumor has to grow to such an extent, block the liquid feces, it has to be at an advanced stage. So it has nothing to do with the anatomy. But basically, common sense says that if a right-sided tumor has to cause obstruction, it has to be in a very advanced stage. Very advanced stage. And that is what makes it worse. Okay. Why have I written worse even for, sorry. Yeah. So a right-sided obstruction has a much more worse prognosis as compared to a left-sided obstruction. Would you prefer to do an anastomosis or prefer to do a Hartmann's procedure?
Hartmann's.
Depends upon the.
Excellent answer. Answer was depends on multiple factors. What is the condition of the patient? What is the nutrition of the patient? How bad is the distended bowel? Do you have enough space to operate? And can you do a colonoscopy and put a stent? So multiple options or multiple factors that influence your decision of doing an anastomosis. Have you heard of on-table bowel preparation?
Yes, sir.
Yes. Now, even if I am not going to do an anastomosis, do I still have to do an on-table bowel preparation? Is there a role for it? Answer is yes.
If you are
See,
unable to find a mass, yes.
correct. If it is so distended and so huge that you don't even know where to resect. Now, please note, this is not a benign disease. So don't do a laparotomy and do a stoma and come out. If you're doing a laparotomy, you might as well resect the tumor. Okay. So if you have to resect the tumor, the distension of the colon should come down for you to identify where the tumor is, which arteries to ligate, all that information you need. So in such a scenario when there is gross distension and lot of feces there, better to do a on-table bowel preparation. So for right side of the colon, they'll make a small hole in the ileum, put a catheter inside, put a purse string, irrigate it and suck out the feces. Similarly, you can do something higher up in the transverse colon and better to go in the tinea. Okay. Again, put a purse string, again wash it and bring it out. Sometimes the feces are so hard that your small catheter that you put can keep getting repeatedly clogged. So the alternative is to do this. Make one hole where the appendix is. Probably do an appendicectomy and through the base of the appendix, you put a Foley's catheter. Start irrigating it from this side. And in the distal end, you will use a fat tube. Now, if you don't get a fat tube, what will you use? Which is the fattest tube that you have seen intraoperatively? In the OT.
ADK drain.
ADK drain.
In the OT. I didn't say table. I said OT. Headed.
Intubation. The Bale's tube.
Boils.
Brain circuit tube.
Bain, sorry, not boils. Bain circuit. That is pretty big, right?
Yes.
So take a Bain circuit, put it inside the colon, purse string suture. So irrigate it from here, get the feces out. You will give an on-table bowel wash. Okay. Then it is left to you whether you want to do anastomosis, don't want to do anastomosis, want to do a stoma, resect, whatever is left to you after that. So this is an image of an on-table lavage. Okay, they've made a small hole and they're pushing in fluid and probably sucking out the same thing. What is this procedure called? What have they depicted here?
Hartmann, sir.
Excellent answer. There is a tumor here. They have resected the tumor. It is probably an obstructing growth. So they have decided not to do this anastomosis. They have decided not to do this anastomosis. So they have brought out the descending colon as an end stoma and closed the rectal stump. And once the patient becomes better, they will go in and re-anastomose it. Only thing, technically what I want you guys to remember, after closing the stump, leave a long thread. Long thread, preferably non-absorbable. Because after 3 months, when you go back in to operate, all this is raw surface, right? So small bowel will go and sit on it. So, and the rectal stump also will shrink because it is not being used. Okay. So rectal stump will shrink. So it becomes very difficult to identify which is the rectum, which is the bladder, which is a small bowel. So this long non-absorbable thread is probably one way of trying to identify where is the rectal stump. Then you go get around the rectal stump, then do your end-to-end anastomosis, and then you're going to get out. Palliative way of managing an obstructed bowel is to put in a stent. Best is this, rather than doing a stoma, best is to put a stent, give them neoadjuvant. Now, one more simple question before we end. This is rectal cancer or colonic cancer? Huh?
Rectal cancer, sir.
Why? Obstruction happens in rectal cancer. That is what
Rectal
I just
cancer.
told you. Forget about the image. I'm saying in general. Rectal cancer is the one which has a napkin ring appearance. That is the one which causes bowel obstruction. When I say neoadjuvant, is it chemo or radio?
Chemotherapy, sir.
It is radio. It is concurrent chemo plus radio, but predominantly the major functioning is of radiotherapy. Now, but I will not do the same thing if it is a colonic cancer. If it's a colonic cancer, I will go in and do a stoma. I will operate and remove it. I will not plan for neoadjuvant. Can someone tell me why?
Sir, there is only will give chemotherapy, radiotherapy you can give because bowel, small bowel
Excellent answer. The idea
enteritis.
of radiotherapy is not only kills off the cancer cell in the rectum, it will also affect the adjacent structures. Rectum is inside the pelvis, so it's a safe area. Nothing else will be in the pelvis. Whereas, let us say colon, here, transverse colon, lot of small bowel in and around this area. So whenever you give radiotherapy here, you can also cause damage to the small bowel, and that can cause radiation enteritis. So for colonic cancers, no role of radiotherapy, whereas for rectal cancers, predominantly it is radiotherapy. Okay, along with chemo, predominantly radio. That also you have short course, long course. We'll not get into it. Please read up. That is not under the purview of this particular topic. If you cannot get the stent across and you think the patient is not fit for a conventional laparotomy, all you have to do is, depending upon where the cancer is. If the cancer is in the rectum, you will do a sigmoid colostomy. Make a small nick in the left iliac fossa or the left lumbar region, pull out the sigmoid colon, make a loop colostomy and get out. If the tumor is higher up, then you're going to do a transverse loop colostomy. And I've told you how we are going to do it. Just to the right or left of the midline, make an incision, split the rectus muscle, find the greater omentum, keep pulling it till you find the transverse colon. If the tumor is much more proximal, then you will end up doing a loop ileostomy. Okay, loop ileostomy, where the incision will be in the right iliac fossa. That's about it, nothing special. Last slide, I think, is regarding inadvertent perforation. Whenever you're handling the bowel in a very rough manner, you can cause perforation in about 7 to 25% of cases. Whenever there is a perforation, there is a reduced disease-free survival. Okay, so idea is be gentle. Now again, it comes back to the fact whether you need bowel preparation or not. So whenever there is bowel preparation or you prepared the bowel, it's much more easy, much more pliable as compared to a loaded colon. Okay. Oh, sorry. One last slide regarding TAMIS, just for knowledge. I've already explained it to you. It should be a T1 tumor and not beyond it. It should be well differentiated tumor on histology. No lymphovascular invasion. No features suggestive of mucinous adenocarcinoma, and preferably for distal 1/3 of the rectum. So TAMIS stands for transanal minimally invasive surgery. Okay. So like how you do a SILS port, you will put a similar port in the rectum and you're going to go operate and you're going to come out. Again, not the purview of this because this is more of colectomies and not the transanal TME and all those. Finally, last slide is to summarize. Laparoscopy versus open, same. Is there a role for extended lymphadenectomy? That is, D3 lymphadenectomy is the best, but don't say because I've come to SMA, I will also remove lymph nodes near the IMA. That is extended lymphadenectomy, no role. It does not help the patient, but D3 is the best. Extended margins, beyond what has to be taken. Don't say I've already taken 10, I will take 15 centimeters and make the patient be 100% certain there is no tumor. Again, no role, or it does not provide any extra benefit. Medial versus lateral. I told you oncologists prefer the medial approach. What I have been brought up with, or what I am more comfortable, is the lateral approach. Again, medial versus lateral, current guidelines say that there is no difference. Both of them have the same impact, okay, or have the same outcome. En bloc resection, that means from the colon, if it goes and spreads, let us say to the spleen on the left side, or if it goes to the kidney on the right side, you have to remove that also. That is called as en bloc resection. Everything has to be removed. Last is when you're retrieving the specimen after doing a minimally invasive surgery, they advise you to use a wound protector. I know it's one of your studies that you're doing for SSB. Wound protector definitely reduces the rate of surgical site infections. So any doubts or questions so far? I know I've gone beyond by about 20 minutes. Sorry. But any doubts or questions?
Sir, how ICG will decrease the leak rate, sir?
That is, ICG per se does not decrease the leak rate, but they have found out that it makes you change your decision when it comes to anastomosis. Now, clinically, I might have done a wrong judgment about the vascularity at that point of time. It might look pink, but later on, there might be no vascularity. It can lead to anastomotic leak rate. With ICG, you're a lot more confident. Okay, you're a lot more confident. Now, we have even proof that there is enough blood supply there rather than just going by pink color. Okay, so that is why ICG say that whenever you use ICG, the leak rate is slightly lesser.
Sir, in in AR, when we are doing total mesocolon excision, what about the vascularity, sir?
Mesocolon, no, mesorectal.
Mesorectal excision
Vascularity of what?
of the remaining segment of rectum.
It will be there because what is the middle and inferior rectal artery a branch from? It is a branch from the internal iliac artery, not the inferior mesenteric artery.
Yes.
Inferior mesenteric artery only goes as the superior rectal artery.
Superior rectal. Yeah.
The middle and the inferior rectal artery is from the internal iliac artery. So that vascularity is maintained. I spoke to that lateral stalks are there.
Yes, sir. Yes, sir.
That is where the middle rectal artery and all come. They are from the internal iliac, not from the IMA.
Yeah.
You knew the answer or you were testing me?
Sir, I am thinking when we are doing a total mesorectal excision, we may sometimes go away with middle rectal also. That's what I'm thinking.
Yeah. That is why the colorectal has worse healing when compared to coloanal.
Yes.
Anybody else? Niranjan sir, any comments, sir?
No, it was an excellent class. Only thing, when we are talking about D3 lymphadenectomy, as you said, the disease-free survival is better, but it should only be restricted to cases where there are high risk of recurrence or in advanced cancers, and also it should be done in a center where there are high volumes, where they are repeatedly doing D3 dissections. Because overall survival, there has been no difference, even though the disease-free survival is better. But if you try to do D3 in a low volume center or person who is not experienced, you end up having a high morbidity. So the benefits of D3 will be gone there. So it is mostly for right-sided colon cancers, and it should be only done for high risk or advanced cases and in high volume centers, not routinely. Because overall, even though the disease-free survival is better, overall survival there is no difference.
No benefit.
With high risk of complications.
Yes, sir. Correct.
Yeah. Otherwise, it was excellent.
Thank you, sir. So, guys, if there are no other questions, can we wind up? Nitya, Nikita, if you guys
No
say
question, sir. No question, sir.
done. Excellent. Thank you all. Have a good night and a wonderful upcoming weekend.
Thank you,
Thank
sir.
you, sir.
Bye
Thank
bye.
you.
Good night, everyone.
Thank you, sir.